Hello everyone, we thank you for joining us for this edition of Health and Family. I'm often asked as to how we come up with topics for our program. This particular program was a no-brainer, as I've shared with you before, as to what I actually do for a living, that being a behaviorist. So that essentially means I work with students who at times display challenging behaviors. So what causes these behaviors? We go to our guest today, Dr. Carla Bean, child psychologist from Child and Adolescent Services, better known as CAS. In the second half of the program, we'll be meeting Mr. Moffat Makomo, who is a registered occupational therapist, also at CAS. But right now, we welcome Dr. Bean to Health and Family.
Thank you.
Welcome. First time. I'm surprised, but it's the first time. So let's start off by defining what childhood trauma actually is.
Well, trauma, the original definition of the word trauma, we go all the way back to antiquity. The Greek word means harm. And so as we evolved, developed, we became to recognize that harm is not just physical harm, because that's what it initially referred to, but that there can also be emotional, psychological harm. So trauma, the definition according to American Psychological Association would be any event that a person experiences where they come close to death, or there is a death experience that they witness or they learn about, that would cause some type of emotional, psychological, even physiological reaction or stress.
Okay. So is there some type of assessment kit you use to determine if trauma has happened to a child?
There is no particular kit per se. There are a list of questions that we as professionals would know how to ask, because we know what the red flags are, we know what to look for in terms of the areas of symptomatology, so we know what types of historical background questions that we might ask. There are also objective measures, so meaning questionnaires that either the individual can fill out themselves if they're old enough, or a parent or caregiver, teacher, someone that has observed the individual enough could fill out on their behalf. And so there are various ones out there that are standardized, and so that we use, you come up with a score if they answer a certain way, and then that would tell us that not in and of itself would be able, you wouldn't be able to diagnose, but it kind of gives you red flags and areas to kind of look into to say with other information, yes, we can make this diagnosis.
So an example of this, would the Connors be an example of this?
Connors is used more for attention deficit disorder, but it has other DSM or diagnostic areas on it, but there's post-traumatic stress disorder questionnaire. Connors could give an idea in terms of if that's an area that we want to look at, and then we would give other questionnaires that are more specific to post-traumatic stress or some type of trauma. There's a trauma checklist, for instance, things that are specific to trauma.
All right, so you talked about symptoms. What are some symptoms that a child would display if they've seen a traumatic event or experienced a traumatic event?
Well, symptomatology with trauma with children, it varies, number one, according to age and then developmental level. So whereas a preschool child would show different types of symptoms or a different manifestation of the symptoms than, say, adolescent or even an adult. So when you're talking about children, you can, anything from early preschool may look like their play may sort of be reenacting a traumatic event. Right. They may avoid contact with adults or caregivers. They may be extra irritable, more tantruming than usual. An adolescent, for instance, may turn to drugs or alcohol as a defense mechanism or coping mechanism, or they may become more angry, for instance, or they may become more violent themselves, acting out. If an adolescent's been sexually abused, they may become hypersexual, or they may become withdrawn from people, things of that nature. So it varies.
All right, so if I'm a parent or a teacher or a caregiver, how can I help my child the child in question to deal with these traumatic events?
Well, the first thing you want to know, what are some of the red flags? So what are some of the signs that the child is experiencing symptoms that are related to trauma, right? So some of the things that I mentioned, and then in addition might be difficulty concentrating. Behavioral is going to be behavioral manifestations. So when you're talking about children, it's more of the behavioral and developmentally related manifestations of the trauma. So recognizing when there's a change in their behavior, they're not acting as they typically would, that there's likely something on loss of sleep, and so they're not concentrating in school the next day. They may be experiencing flashbacks, things of that nature. Dissociative phenomenon could also happen where they sort of almost as if they're freezing or not themselves or not in the moment. So recognizing what the signs are and then being able to see what you're observing with that child would be the best way, and then going to a professional that can help.
And that kind of leads me to my next question. So say, for instance, I witness my child or a child acting out, not acting appropriately in class. And so I may give it some time, but after maybe 2 weeks, a month, and I say, I think I need some help.
Well, and it depends on that child, your relationship with that child, and maybe sooner than 2 weeks. If that child is acting, in a way that's really outside of their norm, and something's just not sitting right, it may be a day or two. You're saying, well, something's going on,
right?
And then so it depends on your relationship with the child, their history, their behaviors, etc.
All right. Initially, you talked about PTSD, post-traumatic stress disorder. Explain to us, does a child encounter this, or?
Children can have PTSD symptoms. I think what's happened in previous years, prior to the new DSM, which is the Diagnostics and Statistical Manual for APA, which we use as our Bible in a sense, to diagnose. So prior, the DSM-4, for instance, didn't have a specific category for preschool age children. So children that were that young, 2, 3, 4 years old, were having the symptoms, but it was being missed because the diagnosis wasn't there. So now with the DSM-5, they have a specific category for, say, children that are 6 years and younger. So yes, children very young can experience, and research has shown as young as 2 years old where they've seen manifested symptoms of post-traumatic stress. The criteria is different than from an adult because it shows differently. Right. But yes, they can have experienced the symptoms.
What would be an example of that, of a post-traumatic stress disorder in a preschool child?
In a child, for instance, as I said earlier, you may see them acting out in play. You may see them avoiding adults. They may be more clingy to caregivers, things of that nature. They may have more acting out, because for young children, you're going to see it more behaviorally. So they're more likely to act out tantrum behaviors, or be more irritable, or there might be sort of what would be sort of a hyper alertness. So they're sort of wary or anxious of people or situations, things of that nature.
So observation is key.
Right.
Okay. So you are a doctor. You are a child psychologist. What are the prevalent cases that you deal with besides? I know you deal with ADHD a little bit, or so just talk to us about that.
Just children's diagnoses in general. Well, we have pretty much, we've hit all the categories with children. So you have your what we call disruptive behaviors. So that would fall under, and impulsivity. So that will fall under like the ADHD, the oppositional defiance, the conduct disorders. We also have our like neurodevelopmental disorders. So we're talking autism. We're talking social communication disorder. You would also have your anxiety disorders, depressive disorders. We even see psychosis, not as common as others, of course, but we also see psychosis. We pretty much hit the full gamut, self-harm, deliberate self-harm, suicidal ideations, things of that nature.
So as a child gets older, do they outgrow these behaviors? Like, is the trauma been reconciled? Has it been talked about so that the child can outgrow this, or?
Well, it depends, and I think you just said what's key is being talked about, reconciled. And so just as with physical trauma, if you get a cut, eventually it's going to heal, but if it's not treated properly, it's not going to heal properly and will fester and cause more problems in terms of that healing. So same thing with trauma. When children go through emotional, psychological trauma, they may develop adaptive mechanisms, but without the proper guidance and treatment, it can turn into other things that are more serious. You know, the child's adaptive mechanisms may not be that effective. So it depends, again, it depends on the child, it depends on the environment, whether or not they have support in the environment, it depends on whether or not they get the proper help that they need.
All right, so what effective treatments are there out there to help a child overcome the traumatic stresses that they may be experiencing?
Right, so one of the main treatments is cognitive behavioral therapy.
Just expand on that just a little bit for us.
Cognitive behavioral therapy is basically our cognitions are our thoughts, and then cognitions lead to behaviors. And so cognitive behavioral therapy is aimed at negative or maladaptive cognitions or thinking that would then contribute to maladaptive behaviors. So we want to change that and make it more positive, so then now the behavior is more positive. And that works particularly well with children and adolescents because a lot of their manifestations, as I mentioned, is behavioral. And so targeting what thoughts are behind that behavior. So with trauma, it's the same. You're going to deal with CBT under cognitive behavioral therapy, which we call CBT. We would look at relaxation strategies, teaching them how to relax. There are other strategies such as EMDR, which is eye movement desensitization, reintegration. So basically, what this is a fancy way of saying the individual, while they are recalling an intrusive or upsetting memory material, they are responding to an external stimuli. So that might be therapist-led eye movements, that might be tapping, things of that nature. So that's not as, the research doesn't show that that is as proven, the EMDR, as cognitive behavioral therapy. So then, like I said, under the cognitive behavioral therapy, you have your relaxation, you have your parenting strategies, teaching the parent how to be supportive to the child, teaching them in the meanwhile how to manage the behaviors, because often the child feels out of control, they can't self-regulate, so you just need plain behavioral management strategies to help them manage that behavior while they're working through the trauma. And so retelling their story, helping to manage themselves and manage their behaviors, to help them, that's the sort of reintegrating the material that they've gone through so that it's more healthy.
And so do we see some positiveness out of this at the end of the day when you work with a child and you do the CBT, the cognitive behavior therapy, and teaching the parent how to work with their child's trauma? At the end of the day, do we see behaviors?
We do see results. We do see results, which is, and that's why that's one of the most recommended types of treatment is the cognitive behavioral. You know, like I said, under that umbrella comes various techniques, and so learning, you have sort of an array to pick from, even to tailor to that child and that family. So yes, we do see positive outcomes, particularly with those individuals that are invested in the treatment, where you have the parent, the child, not only the parent, but the child, not only the child rather, but the parents that are also invested and provide that appropriate level of support, then yes, it can be a very positive outcome.
All righty. We want to thank you, Dr. Carla B, for being so forthright with your answers. Thank you once again for stopping on by. When we come back, we'll meet Mr. Moffat Makomo, an occupational therapist. What is an OT? Stay tuned and find out. We'll be right back. Make your overseas travel affordable and stress-free by sending your extra items and purchases home by using the Bermuda Post Office parcel service. Visit any post office overseas and send your items to your home address. Collect them from your local post office in Bermuda. Save on extra luggage fees, airport customs duties, and courier fees, and track your packages at www.bpo.bm. A message brought to you by the Ministry of Finance.
For you.
Move more, Bermuda.
And we thank you for coming on back. At this time, we have Mr. Moffat Makomo, who is a registered occupational therapist with the CAS. He is going to tell us what his job as OT, what does it entail? So we welcome you, Mr. Makomo, to Health and Family. So an OT, occupational therapist, tell us what that is exactly.
Thank you for having me. So occupational therapist is whereby we put life into living when people are suffering mentally, physically, psychologically. And so we tend to focus on activities of daily living, play skills for children, school participation, social skills, so that the child or adult gains skills which either they previously had or do not have, so that they can function in everyday life.
All right, and so you basically work with children at CAS.
Yes.
And so one of the things that maybe our audience is not aware of is sensory processing. If you could kindly explain that to our audience for us.
So sensory processing, explained simply, basically means how you interact with your environment, how you process information and therefore respond to either visual input, things that you see, things that you hear, things you smell, and how you respond to them and interact with them on a daily basis.
And so because I work with you on a weekly basis, I bring some of my students to you, and quite a few of them are dealing with sensory overload. Talk to us about what that looks like.
So I'll start by explaining when we start having challenges with processing information. You can have challenges whereby information is too much for you, or information can be underwhelming, or basically you have moments whereby sometimes the information is too much or the information is underwhelming, and the response that the child gives would be in terms of behavior. And once we see those behaviors, after assessments, we can be able to determine if they are seeking sensory information or if they are avoiding sensory information. So for people seeking sensory information, it's almost like when we are experiencing certain sensory information. Some people cannot feel pain the same way we feel pain. Like when something is too painful for us, it might just be minute pain for them. So for them, for other people, it can even be sounds. The sounds that we hear, other people cannot hear them, so they almost like look for the sound, or they seek for the sound. So what you tend to see would be people who make their own noises, or people who bring objects close to their ears. They're sort of like seeking that sound. For some people, they can be seeking for movement itself. They are almost always on the go, wanting to move, wanting to fidget with stuff. So that would be like some of the sensory seeking behaviors.
And so I think one of the examples I think our audience could relate to is the little fidget toy, right? That does help a little bit with some of our students.
So different people fidget differently, and we also fidget for different reasons. And just to recap a few reasons, we fidget either to keep ourselves alert, we fidget in order to regulate ourselves and calm ourselves when we are anxious, when we are scared of something. So depending on why someone fidgets, you would find certain fidgets works for certain people, certain fidgets don't work for others.
Okay. So one of the popular disorders that we deal with is ADHD. Is this a sensory disorder to some extent?
So ADHD is a neurodevelopmental disorder, and sensory processing disorder in itself is not currently a formal or recognized disorder. So I wouldn't say there is a connection, but you definitely see that there's always an overlap with how sometimes people with ADHD would present almost similar to some people who have sensory processing difficulties.
All right, what are some red flags that parents should be on the lookout for in dealing with sensory overload processing?
And as I stated initially, for sensory processing difficulties, what you see are behaviors, And so some of the behaviors to look out for might be as simple as your child having difficulties with writing or avoiding writing activities, or your child not performing at the same level in activities such as PE, or your child being clumsy compared to their peers in school, or your child being a very picky eater. And I recognize I'm indicating your child. It is also important to note that even adults have sensory processing challenges. And to even go further, each one of us experiences some sensory processing challenges at some point in the day, in the week. Examples would be there are those days when your mood is kind of different and you can't tolerate any level of noises. You can't tolerate, or examples when people are pregnant and they can't tolerate certain smells or environments. So you'd find at some point we experience those things. The main take-home point that I would give would be the behaviors has to affect function. The behaviors has to affect your day-to-day operation. If it's now affecting the child such that their academics are affected, their day-to-day performance of different things is being affected, is definitely something that parents should take note of and bring forth to the professionals.
Okay. And so how can this be treated? I know when I've been in your company, I'm dealing with some of my students, we looked at the brushing, which was actually to take a brush and to brush the child to alert, correct me if I'm right or wrong, alert the child. Could you talk a little bit about that?
So to kind of go back a little bit, you'd find after assessments have been done and a treatment is done, you'd find sometimes the occupational therapist would devise something called a sensory diet. A sensory diet is a set of activities that are scheduled for the child to do at specific times of the day, almost like meals. That's why it's called a diet. So there's like activities either for the morning, afternoon, evening, but also the activities to be done as and when needed. And one of the techniques used is the one that you mentioned, which is the brushing protocol.
Okay.
But that protocol involves brushing and deep pressure that would be used to help a child, and especially with tolerating certain sensations or helping them to regulate. So basically the treatment for sensory processing difficulties is helping either the individual to be able to tolerate and be able to work with those challenges, or to actually adapt the environment such that the child is able to work better in that given environment, as well as education to the adults in the child's vicinity to be in the know-how so that they can also be educated on it and be able to tolerate how sometimes the children respond.
All right, so let's look at, is there a correlation between the sensory processing and autism to a certain extent?
So you would actually find that the studies indicate about 75% of people with autism spectrum disorder have sensory processing difficulties, but not everyone with sensory processing difficulties is on the spectrum, because if we go back to what I indicated, almost everyone once in a while has sensory processing difficulties. So not everyone with SPD or sensory processing difficulties has autism.
So if a parent suspects that a child is suffering from sensory processing, who should they contact? What can they do to assist with that?
So if the parent is suspecting these, I would really urge them to, one, communicate with either the teachers that have the child, because they also stay with the child for a prolonged period during the day, so they might have also observed something regarding the child, as well as contacting the occupational therapists, either in private or through the schools. They have a good system whereby that information can be passed on to either the school OT or the team itself discusses on where to go with it.
How prevalent is this disorder here in Bermuda? Do we have any stats on that or not?
Unfortunately, there are no figures as to how many people have sensory processing disorder, but I'll tell you that there are figures regarding worldwide that would state between 5 to 13% of the population presents with sensory processing difficulties.
Okay. And so it's nothing that the mom did when she was pregnant or anything that brought this on. It just happens, or is there anything like, you know?
No, so there's actually no known cause for sensory processing difficulties. So it's not the parent's fault, neither is it the child's fault. So it's more or less a neurodevelopmental, if anything.
Okay. So you talked about the brushing as one of the techniques in helping, and in working with you, one of the things I loved, and I've definitely used it in my everyday teaching, is to do the moving activity, and then to do a lesson, then to do an activity. How does that really just explain that for our audience, if you don't mind?
So the basis for the children presenting those behaviors, I'll go into a few examples. If a class is noisy, you'd find other kids would block their ears, or other kids would tap to make noises or even start humming. The question is, why did they do that? They actually do that to drown out everything, and it's a way of regulating their central nervous system. They're trying to calm themselves and regulate themselves. Other things, a child who is fidgety, like I had mentioned, it's a way to regulate themselves and calm their system, because they would have known they aren't at that equilibrium, so it's almost like to bring themselves to that equilibrium. When you wake up in the morning, you are still low. You're trying to pick yourself up. Right. So we do certain things to help us pick ourselves up. If we don't have activities, some people will do other things like drink certain beverages or do other things. So with the techniques that we do in our sessions, you'd find they're meant, or those sensory techniques like the brushing, they're actually meant to help the child regulate themselves so that they're able to continue with their tasks.
All right. Thank you so much for joining us. It's sort of been brief, but at least we've shed some light on sensory processing, Mr. Moffat Makomo. Thank you once again for joining us, Mr. Makomo, and I also want to thank Dr. Carla Bean. They have certainly shed a lot of information and light on this topic. Thank you once again, childhood trauma. On behalf of Health and Family, I'm Shay Burgess. Thanks for joining us.